I was asked to talk about prevention of AKI on a actually applied clinical basis, and these are my potential conflicts of interests, and I will continue first questioning our nephrocentric view, or saying goodbye to a nephrocentric view when we think about prevention of acute kidney injury. We are aware that AKI is influencing the function of many other organs, actually all other organs, in the setting of a systemic inflammatory disease. But we also have to be aware that every dysfunction of another organ is significantly impairing kidney function. It doesn't matter whether it's liver dysfunction or it's gut dysfunction with bacterial translocation. I think it's very well established that the cardiorenal syndrome and the interaction between heart and the kidney, what I want to address your attention on is also that there is a close interaction between the lung and the kidney, and let me show you this interaction. When we start patients on mechanical ventilation, the kidney is reacting with by hemodynamic effects and some inflammatory effects by retaining sodium and water, and this often further impairs pulmonary function, which requires us to increase ventilation pressures. Finally, the whole process, like a vicious circle, might end up by inflammatory mediators in AKI and RDS, because they are working together and enhancing the damage response. So this has been very well shown in animal experience. Some human experiments are also available. If you damage the lung by injurious ventilation, you always damage the kidney, here shown by animal experience, where the kidney cells get apoptotic when you're using high tidal volumes. So if you're preventing further lung injury by using low tidal volumes, and I think this is the rule, but it's not very often exerted as in all the ITUs, then you also protect the kidney. The other thing is fluid overload, or at least fluid retention, which impairs oxygen diffusion, and it has been shown nicely in the FACT trial that when you are going for restrictive volume management, keeping the patients on an equal balance over a week versus liberal, where they had 7 liters plus, then you not only wean the patients earlier, but also have less rate of renal replacement therapy. You see conservative 10% versus 14%. And of course, you have to give a lot of diuretics, as is seen on the other slide. And in this setting, you can say that although we heard before by Mink that we are not using diuretics to prevent AKI, from a systemic view, when we prevent or improve oxygenation or keep pulmonary function improved, then we also protecting the kidney and do an indirect prevention of AKI. And generally seen, it's well established that fluid overload is impairing all organ functions, and they impair then kidney function again. It's interesting that some interventions which you wouldn't consider to be preventive in terms of kidney failure have an effect, as shown here by this small randomized study just published last year, where they compared 2 different sedation regimens, so inhalative sedation with sevoflurane versus propofol in valvular heart surgery. And although the hemodynamics was completely identical, you didn't see any difference. There was a difference in kidney injury, and there was a difference in the AKI stages and the rate of patients who had no AKI, and also in urinary output. Actually, nearly all the endpoints which were concerned with kidney function were better when they used propofol. So you think, how does propofol influence renal function? They didn't provide a clear explanation, but what they could measure as an additional parameter is that they showed there was less systemic inflammation by reduced interleukin 6 and reduced CRP in those patients treated with propofol. It just is additionally supporting the hypothesis. So if you do systemic improvement, then you are doing considerable benefit for the kidney, even if it's an intervention where you wouldn't primarily think it's protective for the kidney. So you have the general measures to avoid multi-organ dysfunctions in our critically ill patients, and if you're doing good medicine there, you're doing already a considerable protection of the kidney, and then there are the specific measures to protect the kidney. And following the recommendations from the KDIGO guidelines, I think the most important thing we can do is to avoid additional harm in terms of contrast media, antibiotics were nephrotoxic, and non-steroidals or ACE inhibitors. We have to consider, however, also the fact that fluids which we very often apply to prevent AKI may be harmful themselves. I won't go into this crystalloid debate because we'll hear more about this later by John, but there are some signals that high chloride containing solutions may be harmful when we use them for volume expansions in terms of opposite to balanced solutions. The colloid discussion has been quite intensive over the last years, and I think now it's quite clear that artificial colloids must be considered as harmful for the kidney when applied. We have just recently showed in the systemic review where we analyzed all publications looking at storage that starches are not only stored in the kidneys producing an osmotic nephrosis-like picture, but it's also stored in other organs like liver and bone marrow, and of course in the skin there is some dose dependency, so the more of give of the starch, the more of storage you're getting, but it's not linear, and the storage occurs already at low doses. And the thing is, it starts quite early, and the deposits might be found years later in organs, including the kidney. And I think such a clear message like this from the Cochrane analysis, where they showed in 42 randomized controlled trials that there's a clear damage signal for the kidney, and a clear recommendation not to use starches, whether it's the big ones, the smaller ones, older or newer ones, and independent of the dose. It harms the kidney. I think this is clear. On the opposite, when you're looking at biological colloids, as we have shown in a couple of years before in the meta-analysis, where they had AKI as an endpoint, whereas a clear signal for renal damage when you're looking at hyperoncotic starches, there is a signal for protection or not damage, no harm, for albumin, hyperoncotic albumin, when you look at summarize these trials. And this meta-analysis has actually been confirmed with two large randomized controlled trials. One has been only published as an abstract, but the Caironi trial has been published last year. And I think it's clear from randomized controlled trials that there's no signal for damage on albumin, hyperoncotic albumin, in terms of AKI or increased requirement of renal replacement therapy. So colloids seem to be at least neutral, and if albumin used as a biologic colloid. So avoiding additional harm would then include avoiding fluids which are potentially harmful for the kidney, like starches and colloids. About gelatin, I think the debate is still open. Now, the next and second major goal is just to keep our kidneys adequately perfused, and hopefully then they stop decreasing the GFR. And how are we doing this? You are optimizing volume status, you use vasopressors and inotropes, and you have to estimate the individually required perfusion pressure for your patients based on their previous history. Very often, especially if the patients are sick, then you will need advanced hemodynamic monitoring to ensure that these parameters are adequately achieved. And I think just to emphasize this again, the only reason you give fluids is to increase cardiac index and oxygen delivery. So, for example, if you give a fluid bolus and you get as a response an increase in cardiac index, your CVP may go up or not, then I think this made sense. It does not make sense to give fluids if your cardiac index is not increasing further and only the CVP is going up. And so the only reason to give volume expansion is to improve cardiac index. And in terms of hemodynamic parameters, the normal range of cardiac index is of about 2 to 4 liters per minute per square meter, but we don't know what is the individual optimal range, so we use indirect target values, which is lactate clearance and SVO2. And I think if we consider this to be in the normal range, then most likely the optimum cardiac index has, or oxygen delivery has been reached. So we're using indirect parameters for that. The other thing in terms of volume therapy is that you don't only have to identify the volume responsive AKI by optimizing systemic hemodynamics, we have to identify also these group of patients who will not respond to further volume increase. We know that the filtration gradient by John Price's work, the effectiveness is very small, and if we get edema and venous congestion, then the GFR might be significantly impaired. Do we have any parameter which can give you an indication that the patient is getting volume overloaded? The CVP has been heavily discussed and even suggested to be discarded from our hemodynamic armamentarium. But on the other hand, I think this study again from Mathieu Legrand shows that there is an association between high CVPs and AKI. So I think when you have a continuously increasing CVP, you might consider this as an early signal for volume overload. Concern with regard to the individualized optimal perfusion pressure, we had already seen this slide from the ASFA trial, where the in septic shock compared two perfusion pressure targets around 70 and the other one around 85. Actually, it was then 75 and 85, and that in the predefined subgroup of chronic hypertension, they had less AKI on the other hand, and which was defined as a doubling of plasma creatinine, which was considerably lower in the high target group, and they had less requirement of renal replacement therapy in this group of chronic hypertension. You buy this benefit on some costs, and the costs are that you have increased duration of vasopressor requirements and arrhythmias. So maybe that's why they also couldn't see a primary benefit in the primary outcomes. What is interesting is that all interventions which were specifically aiming at selectively doing a renal vasodilatation and just improve renal perfusion somehow, like dopamine, prostaglandins, natriuretic peptides, endotheliin antagonists, were more or less failing. There have been some small trials with some signals, but overall the large trials never confirmed that there is a benefit. And I think the latest negative trial was with phenolidopam, where they thought, okay, we have a selective DA receptor agonist, and maybe this should avoid any systemic problems which we see with dopamine. And I think this was a very important study done by the Ladoni group in cardiac surgery, where they investigated the effect of phenolidopam being protective for AKI or not in about 700 patients, and as you can see here from the creatinine levels, there was no difference in each group, so it was basically a large negative trial. One explanation why phenolidopam might not have worked or might have lost any benefit, which was seen previously in several studies, especially in contrast nephropathy and in several meta-analyses in cardiac surgery, only this large trials and did not show it, is the problem may be the fact that the patients on phenolidopam had considerably increased rate of hypertension, and they had lower systolic and mean arterial blood pressure as compared to the control. So maybe the adverse effect was becoming predominant, so that there's no effect which could be seen in terms of protection. Now finally, over the last 20 years, all interventions to improve renal metabolism or to reduce inflammation has not been successful, but lately there have been some studies which give new hope. They could be summarized as being interventions which reduce renal inflammation or increase renal stress resistance, so like the resistance to oxygen radicals or hypoxia, and the substances are statin steroids and remote ischemic preconditioning. So statins are well known for their anti-inflammatory properties and the ability to improve endothelial function and anti-apoptotic effects. It's interesting that there have been actually 4 large trials showing a beneficial effect of statins in terms of prevention of contrast nephropathy. I only summarize you the most important ones. This was the single center, the first one is the single center study of 400 patients investigating atorvastatin starting before elective coronary angiography, and the CA contrast-induced AKI rate was significantly reduced in that group, and this was reproduced by a large study of 3,000 patients, all with impaired chronic renal function and diabetes, and by elective coronary angiography or peripheral angiography. Rosuvastatin was protective, although they started 2 days before. The last study which I wanted to show you is the Prater ACS study. I think this is very important because in addition to just showing that there is a reduced rate of contrast-induced AKI by another statin, so rosuvastatin, in a considerably large trial of 500 patients, again elective coronary angiography. And the important message about this study is that an overall hard endpoint, so overall adverse events, were also reduced in this statin group. So at least in contrast nephropathy, I think this is a promising approach. It has been not shown to have any benefit to give statins in other settings of AKI like cardiac surgery. Talking about cardiac surgery, this is an interesting sub-analysis which has been published from the DAX study, which was a very large randomized control trial on giving high-dose dexamethasone 1 milligram per kilogram intravenously during cardiopulmonary bypass surgery, and it had nearly 4,500 patients. They didn't have any difference in the primary endpoints, but doing a subgroup analysis with regard to kidney, the rate of acute kidney injury showed that the dexamethasone group had a significantly lower rate of AKI, and especially lower rate of AKI requiring renal replacement therapy, and also lower stages of rifle class AKI risk. Then later on the numbers getting lower, so the significance may have become lost for that reason. But there is a signal which seems to be quite interesting by using an anti-inflammatory medication in cardiopulmonary bypass surgery. Finally, ICP. I don't go into detail in this. Basically, you're just making a limb ischemic for 5 minutes, and I only want to set the stage for John, who is talking extensively about these topics. Basically, they showed in contrast nephropathy 2012, and this has been followed now by a study by John. He will present it definitely to you, that they could reduce creatinine and cystatin C increases in contrast patients who receive contrast by doing preconditioning. So I think these are very promising approaches. I think they are also have to be declared as a work in progress. We need further trials before we can just go into daily practice for that, but I think the time is very near. It's also true that the only time when we saw that the pill is really working for AKI was when pill was treating AKI, and we're looking forward to new developments. And I think at the moment our preservation and optimization of renal function is doing quite good hemodynamic management using sensible endpoints, monitoring intra-abdominal blood pressure, avoid artificial colloids, especially starches. Albumin may be an alternative in some situations like sepsis, and avoid chloric-rich solutions. Vasopressors, noradrenaline is first choice. We combine it then with vasopressors if it's necessary, and refractory and inotropic approach might be more interesting with laser cement. And I haven't shown you the details because it's not very recent new data. It's quite old, so I didn't want to go into details with this. And of course, we have to avoid nephrotoxins. So I think these are the evidence-based procedures we can suggest, and we are waiting for new approaches, which I think will be ready within the next few years. Thank you for your attention.